Welcome, everybody. I hope we brought your bathing suits. I repeated that. Whoop. Okay. Hi, is that Khalif? Is that Khalif from Kenya?
Yes, John, it's me. How are you? Long
Hey,
time.
I saw the name. I said, no, where's he been?
Yes, I got lost for a while.
That's all right. Did you ever make it to Cornell?
No, the COVID issues
Oh, okay. So maybe
happened.
later,
Yeah,
maybe later.
maybe later. Yes. How is it going in Miami?
Oh, it's great. It's great. It's the best time of year.
Wow,
They
great.
call it the King's Month because it's not too hot, it's not too cool. You know what I mean?
I see.
But the rest of the months get very muggy and hot. And I'm sure, is
All
it
right.
like, I don't know if it's like that in Kenya. Does it get muggy in Kenya?
It does. It does. It does. Around May, June.
Yeah. You know how some months are good, some are kind of not so good.
Yeah.
So anyways, so that's great. So yeah, we're really going well. We're
Yeah, I see.
we're doing a lot with Borba with the WFNS now,
Yeah.
which is good for the name, you know, to get associated with that organization.
Sure.
So yeah, anytime you want to do something or have any ideas, we're always listening.
I'm at break at the moment, but I'll be back in a few weeks.
Well, where are you at now? In Kenya?
I'm in Nairobi.
Oh, okay.
Yeah.
Okay, very good. So you've been there for a while?
Yeah.
Oh, okay. Are things starting to, are you still looking into going to Cornell or?
Yeah, I'm still working on that, but the issue of COVID and then the university hasn't responded that much. I finished training, so
So you're working as a neurosurgeon now?
yeah.
Oh, good for you.
Thank you.
And you'll be staying there for a while, probably, right?
Yeah, so I'm now interested more in endovascular, in stroke treatment.
Okay.
Yeah.
Okay. Yeah, we start various communities. We just started a spinal deformity community.
Okay.
Because we had a neurosurgeon from Arizona that's very interested in spinal deformity. So he wants to start a group. So, you know, we're open to ideas on
Yeah.
you know, starting in different areas. And
Very good.
we do them just twice a month because that's not too much. I think it's just about enough. But anyways, just think about it and to think of if there's anything specific you want to do. So. So no traveling at all for you, right? Okay, I'll be back. Ooh. Hi, Stephanie.
Hi, doctor. Good morning.
Good morning. How you doing?
Great. My doctor said he was going into surgery and that we didn't have to go to the hospital just before I was going to leave. So perfect timing.
Okay. Do you want to host because she hasn't showed up? The host.
Okay, it's fine.
Yeah, all you do is just introduce. It's a minimum. You saw the description of the conference, right?
Yeah.
Yeah, just give a, you know, introduction to Ashish is hosting. His name is Ashish. He'll be coming in shortly.
Ashish
But,
Tandon. Yeah.
right. I want you to meet Khalif. Khalif, the neurosurgeon from Kenya.
Hi.
Okay, I'd like you to meet Stephanie. She's a student that does a lot for neurosurgical TV now.
Very good. Very
Yeah,
good.
yeah,
That's
she's
very
Good morning,
she's helping
doctor.
out.
Hi.
Khalif is a neurosurgeon in Nairobi, Kenya.
Yeah, great. I was listening. Very good, doctor. So I think you will go to Cornell very soon. And it's
Thank
great
you.
that you are now working as a neurosurgeon.
Thank you so much.
Yeah, so we'll be starting. Yeah, Stephanie. It's basically the minimally invasive surgery community or group, and you got Ashish's description there, what he's doing. He's a neurosurgeon from India. Oh, Ashish, there you are. Hey, Ashish.
Hi,
Good
John.
morning. How are you?
I'm fine. How are you?
Very good.
Great.
Okay, I'd like you to meet Stephanie. She's going to be the student that introduces you.
Oh, wow.
Morning,
Okay,
Dr.
and
Ashish.
then
An honor to meet you.
this is Stephanie. And then you just do what you want to do. Just run the show from there, okay?
Yeah, sure.
Okay, and the speaker hasn't arrived yet.
So I would be starting, John.
Okay.
I'll be presenting my, continuing on the last time's lecture, part 2.
Okay.
And then he'll be joining. He called me up that he'll be in surgery. He should be finishing in another 15, 20 minutes.
Okay, no problem. I'd like
Yeah.
you to meet Khalif. Khalif is the neurosurgeon from Kenya. Ashish.
Oh, hi.
And then is
Hi,
from
Ashish.
India. So he was going to go to Cornell, but the COVID changed everything. So he's sticking in Nairobi. Just started to be practicing neurosurgery as a neurosurgeon.
True.
So it's a big time for you, right? Right, Khalif?
Sure. Thank you so much. Glad to meet you, Ashish.
Same here. Thank you.
Okay, we got 5 minutes. So yeah, he was called to surgery. Yeah, Khalif was doing a lot of webcasting for a while there. We had, Khalif, have you done anything with that lab? They were kind of talking about doing something with the lab, but I don't know what happened there.
So there was a plan to do something at the lab that we planned last time. Then we were supposed to have a conference for CANS. CANS is the Continental Association of African Neurosurgical Societies. But unfortunately, COVID happened. We're planning to do that in November this year, second week of November.
Oh, okay. So yeah, we'd like to be involved. Televising that.
We'll be involved surely, and then we'll do the lab at that time as well.
Yeah, it's going to be there's only one other lab, right, in Algeria?
Yeah, in Nairobi.
All of Africa, right?
Yeah.
That's amazing. Is it Algeria the lab's at? Oran or something? Oran?
No, there's one in Morocco.
Morocco?
Yeah.
Okay. That's the only other one?
We're going to have one in Nairobi soon.
Oh, good. So it's a definite. That's great.
Sure.
Yeah, the last time we really had contact, Ashish, there was discussion of starting a cadaver lab in Nairobi. Because if you know cadaver labs, you need refrigeration. You got to refrigerate those corpses. So,
John, these cadaveric courses are extremely common these days.
Are they?
Yeah, extremely common. We keep on, like I'm organizing on 29th and 30th of April. I had told you, I discussed it with you.
Okay,
When you will be in Mexico, you said.
okay. Well, yeah, we'll certainly like to televise something like that. That would be great. That would be great.
Yeah, so it's on 29th and 30th of April.
Okay, I'm
And it's
televising from Mexico at that time, but tell me about it. Tell me about it.
So basically 29th and 30th April. So 29th is Friday, 30th is Saturday. And the first day we are doing an endoscopic endonasal pituitary tumor course.
Okay.
And the next day it will be skull base temporal region. So both the days we have cadaveric courses, and I think we can try to relay live the cadaveric workshop, especially the demonstration part of it.
Okay.
And then it is it starts from 8 to 1, 8:30 to 1. And then 1 or after lunch, we have lectures till for 4 or 5 hours or so.
Okay. So
the conference is divided into 2.
We've kind of done some of that, but it was kind of a rough cadaver lab. It was, we had, because with cadavers, you have to have special cameras, like the overhead camera is very important. I don't know if you used that before or not, but
because most of it would be microscopic or endoscopic. Okay. So, we'll relay it direct.
Yeah, as long as you can get on the screen, we can televise it.
Yeah.
If you can get a good image, whatever.
Yeah, true.
Whether it be from a microscope or what. So we're going to start in a minute, okay?
Yeah, sure.
Nicole's a veteran. Now, she may go to Mexico City to televise one of our conferences from Mexico City.
Mm-hmm.
You know, Stephanie, you're going to be around 3 o'clock
today?
Yeah, because I have a meeting with Erica if you want to come to it.
Yeah, doctor, I am free.
Okay, I'll let you know when I'm going to have it, and then it'd be nice for you to be there.
Yeah, thank you.
Because they're not, bringing me there. Maybe they'll bring you there.
Hopefully, that would be great.
So, and it would be great to have an assistant there. I think it would improve the possibilities of televising.
Yeah,
to have someone like you there. I mean, to be able to move around and do stuff.
Yeah, doctor. So, it would be great. And also doing the short interviews to
yes, of course. You'll be televising the best. You're going up to them with a microphone and and asking questions and making it like the Super Bowl or the World Cup. The World Cup.
Yeah. Maybe.
Let's see here. Okay, someone's got their microphone on. Oh, that's you, Ashish. Okay, you ready? You ready?
Yeah, I'm ready.
Okay, here we go. Here we go, Stephanie. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Good morning, everyone. Thank you for being here. May you receive a warm welcome from the steering team of Neurosurgical TV, run and created by Dr. John Bennett. Here we have the opportunity to host again the session of Minimally Invasive Forum from Spine. And here we have the honor to receive Dr. Ashish Tandon, a neurosurgeon from India, Jabalpur. So now you can talk, doctor. Thank you for being here. Thank you for organizing this wonderful event, and you may take over.
Well, thank you so much, Stephanie, for the introduction. And this is Dr. Ashish Tandon. I'm a neurosurgeon practicing at Jabalpur, India. It's a central part of the country, very beautiful area with rivers and, we have dams. And so it's a beautiful part of the country right in the center. Coming to the lecture, this is the second part of the lecture that we had about a few weeks back. Let me share my screen. Can you all see my screen?
Yes, yes. Do you want to make it full? There it is, full screen. Perfect.
Yeah, yeah. So the first 5 minutes, I'll take the audience through what we have sort of discussed the last time. And thereafter, I'll try to jump into the main part. So this was the last few slides that we had discussed. Today, we would be obviously talking on giant pituitary tumors and how to attack them, how to get a good result. So, sorry. Okay, so we know the classification, and if you look at NOPS grading, then that was the grading which was very much related to the carotid and paracellular extension, which is extremely important for us to know. And then you have the Hardy's classification. So here is a large tumor that I had shown the last time with good extension laterally and superiorly as well. And then I had shown you the result in post-op SAG and coronal, all done through a pure endoscopic view. Then I had also shared this video. And finally, I had come on to how to deal with these giant pituitary tumors. So in the first part, I had discussed how I use lumbar drainage, how to position the patient, what I use as a two-surgeon four-hand technique, white cellar opening, where we use Doppler. In fact, rather, we use Doppler in almost all cases. And then today, I would be dealing with the part 2, which is technique of dural opening, how to excise the tumor, the type of scopes and instruments that you should be using. And then I will share a few of my cases. Reconstruction and CSF leak and repair, I would be dealing some other day. So these were the papers which I had discussed the last time, that why lumbar drainage should be used and what is the role of lumbar drain. So again, coming to the same thing, I do use it, and it needs to be studied and to use in a fashion that helps the surgeon and not just create that cavity. You need to fill it back as well to avoid hematomas. Then we have the 2 versus 4-handed technique. I use the 4-handed technique, which I had discussed. The position I had informed, why a wide cellar opening and how to attempt the wide cellar opening, I had discussed. Then the basal anatomy. All this, I think you can go through the first part of the lecture, and that's available on Neurosurgical TV. Sorry. So all this is available on Neurosurgical TV, and if you look at the pituitary tumor giant excision technique, you will find this. So let me skip all this in the best interest of time, and then we reach to the second part. So I take you right to the second part here. Okay. Now, please feel free to interrupt me whenever you feel like, and I'll be there to answer you. John, you're muted.
Yes, doctor. Sorry.
Yeah, I just wanted to know how to take these names that I'm getting on top.
You can move the superior bar to the bottom.
Superior bar to the bottom. Let me try it. Okay. Okay, that looks better. Okay, can I just get my photographs? Anyway.
Yeah, you can also minimize it so that it only appears your name.
Okay, great. So the second part would be important areas to bear in mind. And the first, as you can see here, is the technique of dural opening. So basically, I'll talk on that first. Now, here is a short video to show you my technique of opening the dura.
Carotids in the cavernous sinus. So we go right to the extreme, exposing the carotids. The dura is opened in a V fashion in large tumors, and we keep a flap of the sellar dura hanging superiorly. This, we believe, just helps in keeping the superior part of the tumor.
So here, what I've shown is the way I open the dura, and what this dural flap does is it keeps the superior part, the cranial side part, still being supported by some dura, and there is the diaphragma does not try and sneak and fall down. So this is a very small technique, but in giant tumors, as you all know, that these small steps help us. And here I would emphasize that when you open it in a V, the flap above is supporting it, giving just a little bit support. And then you can sort of deal with the lower part of the tumor or the sides of the tumor. And only once all that has been dealt, do you go cranially. Now, the instruments and scopes that one should use, or that's what I use. For the nasal part of the surgery, we start with a 0-degree scope. We expose the sphenoids, the whole of the sellar floor till the lateral part. So the whole of, from cavernous sinus to cavernous sinus, the whole sellar floor needs to be exposed. And then from anterior intercavernous sinus to posterior intercavernous sinus, that whole area needs to be in front. Now, remember, in most of the, in fact, all of the giant and large tumors, you should have maximum exposure. Then you start tumor decompression with the 0-degree scope, finish the lateral part, finish the inferior part, finish the area towards the clivus and the part going straight down. You decompress all that with a 0-degree scope. Do not change your scope, because handling the 30-degree and 45 or 70 degrees is not an easy task. The coordination between you and your ENT surgeon, or you or your other neurosurgeon, will become more difficult when you take more angled scopes. Little easier with 30, extremely hard with 70. Okay, so try to push it as later as possible. Now, the 30-degree scope, or for that matter, 45 or 70 degrees, you change that and start using 30 and 45 when you're dealing with the anterior and superior part of the tumor, because that is where you need an angle to, get into and see beneath. So to do that, you need angled scopes now, because you need to look up. And as I have already written here, you need a better coordination. And the best way I have learned is to move a little more slower. You try to be fast, and your whole surgical time would extend. So just go smooth, slow, steady, and you would be able to handle the tumor better. Now, unlike microsurgery, where we use bayoneted instruments, we use straight instruments here, as I have shown you in these photographs. Okay, and we prefer single shafted instruments, because the nasal opening is small. Between the turbinates and between the in each of the nostril, to get bi-shafted instruments is very difficult. So, especially like this bipolar. So these make your life very easy. And also something to remember is if these instruments are angled at the distal end, if you look here, they're angled at the distal end, and here as well, it angles at the distal end. So that also helps you see through the scope. So straight instruments mostly, and at times you should also have the liberty to use angled tipped instruments. So this was the types of scopes and instruments. Now I would shift to the main part, and that is the technique of tumor excision that I use. So again, to come on to the same video here.
Welcome, friends. Today, with visual decline with hypothyroidism.
So this patient is a middle-aged male presenting with increasing headache for 6 months, visual decline for 3 months, right more than left, temporal more than nasal. And then he had severe decline over the last 2 weeks. He had no chronic illness, no addictions. However, his hormone profile was severely deranged. He had hypothyroidism, which took us about 10 to 15 days to correct it. And during that time, we were very watchful of how his vision is deteriorating. We were lucky that he was not deteriorating any further, though we had to start steroids because of the low cortisol as well. But it was controlled.
Steroidism and low cortisol levels.
So here,
his MRI was suggestive of a contrast-enhancing cellular suppressor.
If you'll appreciate here, there's a large SAG component, large coronal component. The third ventricle is being pushed up, the floor of the third ventricle. However, there's not a major lateral extension. If you appreciate, if you see on the axial, there's not a large lateral extension. So it is basically a single tumor going up. This was the perimetry of the right eye. And this was showing the left eye. So severe decline of vision. And so we had to sort of take him as early as possible. Now, this part is done by my ENT partner. And using a 0-degree scope, we tend to separate the we expose the keel, the vomer. Here you will appreciate that the sphenoid sinus opening is there, and we have opened. At times we shrink the turbinates. We avoid any excision of the turbinates. Here we are going across onto the other side to expose the vomer and the keel on the left side. Now the whole keel of the sinus of vomer is right in front of us. We have exposed from superior to inferior. We do not need any sort of radiology confirmation. For the larger ones, larger part of the bone, I use chisel and use mechanical instruments. However, for the fine part, I use either drill or I've started using ultrasonic bone knife. Now, in this case, the cellular floor, the tumor had eroded the cellular floor in this area, though the dura was intact and sort of started decompressing. I've brought this video. It's a very slow video to show you all that I do stepwise. It's a 5 to 8 minute video, and just stepwise each and every step. Here we use either diamond drill or regular drill. This is the Doppler. I'm a big fan of Doppler. You can see the blue shining sinus here. So I expose sinus to sinus. And here I'm confirming the, let me show you this part again.
From the tuberculum sellae right up to the clivus. Here I'm using the Doppler to find the position of the carotids in the cavernous sinus. So we go right to the extreme.
Now, this part I've already shown you that I open the dura in a V fashion. And also it is for the audience, just remember the part of the tumor which is being covered by the dura. Do not deal with that. It tells you time and again that stay away from that part of the tumor during your initial phase of the surgery. Okay, that is one thing that is biggest cause of residual tumor. And here, if you will appreciate, again, straight curettes and angled tip, and I'm starting in the posterior and lateral part. This is the left side, which I'm excising here. All through 0 degree scope. Do not use the curette a lot. Try to suck out as much as possible. It is much more controlled. So once you've got the biopsy, use suckers more than curettes. So here I've been using curettes more, but my advice would be to either take 2 suckers or just 1 sucker and the sort of curette helping. Now here, if you see, my curette is just retracting the dura and my suction is doing the job. Now these are very soft suckable tumors mostly. And you really don't need a lot of curetting, especially when you're reaching the posterior pituitary or the normal pituitary. Do not scratch a lot. You will have more of posterior pituitary symptoms. Now here, till this point, now you see this cavity is increasing in size. I'm sorry. But still, I am using a 0 degree scope because of the drain, because of the way we have opened the dura. Everything is not falling in. I am still under control. I can see very well what's happening. And, I am in no hurry to excise that, the diaphragm is going to fall. It is not. Now, after this point, once a huge cavity is created, as you can see, I have started excision of the tumor, which is just superior under the dura. Here, once this, you see the suction, the angle of the suction, these are angled suckers. And now I'm using a 30 degree scope. So here is a 30 degree scope with an angled instrument. And as you'll appreciate, we are looking, look here, and let me pause. Okay. Now look here, this part of the tumor was excised through a 0 degree scope. And this part is under the dura, which will not be clearly seen with a 0 degree scope. And you need a 30 degree scope to visualize this tumor. And to get that tumor, you need angled suckers. Straight suckers will not. Now look here, this is an angled curved curette, which is still helping me. And this is an angled sucker. And because it's a 4-hand 2-surgeon technique, I mean, in both of my of my hands, I have instruments. Now, this is the fag end, and here we have shifted to a 45 degree scope to excise and complete the tumor. At this stage, almost toward the end, we are coagulating and shrinking the dura, which was cut in a V fashion. And just appreciate here, we are using a 45 degree scope and we can see the dura. This is the clival posterior part of the dura. This is right lateral, supralateral part. And where my cursor is, this would be the part where it's going toward the 3rd ventricle. And so after this stage, once we are very sure of the hemostasis, though I must confess that in this patient, we did develop some amount of hematoma. Here, as you see, now we have started pushing saline through the lumbar drain, and there is Valsalva going on to sort of bulge. So to push the diaphragma down. And finally, a little bit of reconstruction with the just with the mucosal flap that was taken. And basically that ends the tumor. I would thank Dr. Adgaonkar, who is my ENT colleague, who keeps on helping me excise these large tumors. And we have a long-standing partnership and coordination amongst ourselves. Okay. Now, this is another video wherein Professor Chandra from All India Institute, Professor Sarat Chandra, he has developed a sort of a malleable retractor. It's not yet very popular, but I would want you to have a look at this video as well. It's a very short video, again with a large, moderately large tumor, not very big. And I brought this just to demonstrate the type of retractor that he has developed. The large necrotic area in here. Again, typical opening of the sphenoid ostia, drilling. And just have a look at the superior part. You'll see, yeah, look here. This is the retractor that he has developed. So it is a malleable retractor. You push through the nostril and it keeps the nostrils open, the nasal passages open. So that is what basically it does. And this is, you can try it. They've started, I'm not very sure if they've started marketing it, but you can try in a few cases. So having shared the technique, I would take you through certain of my cases. And in the last few slides, I'll deal with my complications. So here's a patient with right cavernous sinus infiltration. Now look here. This is a tumor. This is a tumor here going beyond the carotids right up to here. So a straight tumor in an open sort of a aerated sinus, having eroded a large part of the clivus, dumbbell shape in few areas. And look here, the tumor is going right beyond in here, as well as on coronal contrast. So this is the post-op, a near complete excision with just a small residual left in here, otherwise a complete excision. And so the question is, can we achieve, the question here is, can we achieve a near total excision in a tumor which is extending into the cavernous sinus? Okay. So before I go on to this case, I would like to invite the audience, and the question, I'll show you this scan. This scan shows a lot of things. And can anybody tell me how we were able to achieve this excision beyond, without, getting into the cavernous sinus? We did not get into the cavernous sinus. We remained outside the cavernous sinus, and still we were able to excise this much of tumor. Anybody can take this. If you want, I can show you the scans again. This is the coronal, this is the sag here. Do participate. Anybody, any guesses? Please unmute yourself and go ahead and speak.
So, Dr. Ashish, is it possible that the tumor, even though was extending...
Anybody wants to take this?
Yeah, may I?
Yes, Khalid, could you please introduce yourself, please, Khalid?
Hi, Dr. Ashish. My name is Dr. Khalid from Nairobi.
Please unmute yourself.
I did. Can you hear me?
Yes, we can. Go ahead.
Sorry, I can't hear you.
Oh, I'm sorry, Ashish. We can hear him. I don't know why.
Yeah, sorry. Yeah, I can hear you now.
All right. Thank you so much. Now, is it possible that even though the tumor was extending beyond the midline, you were able to pull it out because it wasn't attached to the structures around it, and therefore it just slid while you are pulling the midline part? Is that a possibility?
No, I don't think so.
Okay.
Yeah, so as in any of the pituitary surgeries, no pulling.
Yeah.
sucking or using a CUSA if it is a firmish tumor, but no pulling, because you can, really tear the carotid or tear into the cavernous sinus. Okay, I'll give you a hint to all of you. The hint is, anybody?
Yeah, Ashish, Harshad Parekh.
Yeah, hi, sir.
Looking at your scans, I feel the tumor is pushing the carotids rather than involving it. And the
Excellent,
carotids,
sir. Excellent.
And I feel the cavernous sinus is being pushed to the one side.
Yes,
And
absolutely.
I would put it as a grade 2 tumor of Atul Goel's classification, or grade 3 maybe, not engulfing. And if you go laterally, far laterally, maybe you will not, and you are a very great fan of a Doppler, maybe you will be able to save the carotids and you will be able to remove this tumor going laterally. This is what my personal feeling.
No, you are absolutely correct. I would want all of you to have a look at this part. Look at the carotid. The carotid is being really pushed laterally by the tumor. The cavernous sinus has pushed it. And it is not beyond the carotid in here. So when you see this, you really don't need to put in a lot of effort and this tumor will come out. However, there is a part of the tumor which has gone beyond the carotid if you look here. And this is the part of the tumor I was not able to excise.
It is wiser to leave it.
Yes. So we have been following this patient. He comes to me every 6 months to a year. We've got scans and it is still the way it is. It's not growing. So do study your MRIs pretty closely. You may really be able to excise a lot, much more. And also you may be able to decide on an endoscopic endonasal approach rather than, going to the transcranial route. So study your MRI pretty well. Now, this is another case, a pre-op, a huge tumor right up to this part with a lot of lateral extension, extensively eroding the skull base all over. And if you look here, the tumor eroding the complete, occupying the complete sphenoid sinus, part of the planum and tuberculum area has been eroded. Then the clivus is all gone, only a part of the clivus is left here. So again, a huge tumor, and this tumor in here has eroded. It's almost reaching up to the basilar artery. And this is the post-op we could achieve. So, and what you see here is the fat and the flap. The fat is really seen because there is a huge cavity and we decided, otherwise normally we avoid, and I'll show you why. But in this case, we decided to go ahead. And this is the post-op axial, the whole tumor all gone here from this area. This is another case. Again, look at your vessels where the vessels are in relation to the tumor. And this patient had severe visual compromise again. And now this is my worst complication. So let me complete and finish off my lecture with my complication. This was the most dreaded complication. And on retrospective analysis, I had made a lot of mistakes. This was a case way back in 2008, 2009. A gentleman who had a straight sort of a tumor, dumbbelling here and causing hydrocephalus. There is gross hydrocephalus, if you appreciate. Post-operatively, there was superiorly a large residual tumor, lot of hypothalamic region edema, increase in the hydrocephalus. We performed an EVD. We gave all which we could. However, the patient really deteriorated and we lost him on the 6th day. This is one of the uncommon or rarer mortalities that you will have in a pituitary. This is another case, pre-op headache, hemianoxia. Look at the tumor here. And this is the post-op. Now, what my ENT colleague did here was overpacking. And though the patient is absolutely fine, no problem with the patient, but when we saw the post-op scans, we were really afraid. And he had a small intra-op leak, and this is overpacking. So the lesson that we learned is in smaller tumors, this is a relatively smaller tumor, just be very careful with the amount of packing you're doing, and don't be overzealous in packing. So after this case, we rarely package, rarely. And this patient is under our follow-up for last 6 years. If you will see here, this is 2016. So for last 6 years, this patient is under our follow-up. He's doing fairly well. And I think the fat must have shrunken by now. I think this is the post-op. Okay. So extremely thankful for all of you who have attended this lecture today. And I'll be more than willing to take up any questions that you have or comments.
Very good.
Yeah, Ashish.
Go ahead, Ashish.
Ashish, this is Harshat Parekh again.
Yeah, hi sir. Hi sir.
See, excellent. Few tips I have really liked what you were saying is, one is the opening of the dura and leaving the flap with superiorly so that you don't go superiorly first. And that is a good suggestion. Second thing I liked, because this is what I have experienced in my practice, and recently I've gone through a very bad phase in the pituitary tumor of one case. And second thing, what is that, don't curate too much superiorly. You can end up with a damage to the normal pituitary or pituitary stalk. And we have found this thing. Third thing is overpacking. I agree with you. We should not overpack or overzealous. And I just wanted to ask you, suppose you removed a pituitary and patient wakes up and says, I can't see anything. And we take the patient to the CT scan and see if you've got an intraoperative, you can see it, and we find that there is a residual tumor, and which is maybe the chiasmal compression is same, but still the patient says, I can't see. So what do you do in these cases? I don't have a slides to show, but I have recently a problem in this patient.
So the deterioration,
Immediate post-op.
Yeah. So the deterioration happens, as we are all well aware, because of the edema that is already, the nerves are compromised, stretched over the tumor. And if you're not relieving the tumor, we know that any further stretching of the nerve, edema, ischemia will lead to a sudden visual decline. Now, if you look at some of the visual perimetry that I have shared in this lecture, in both of the patients where I shared the perimetry charts, you see on the right side of one of the patients, there's hardly any vision. On the left side also, half of it is gone. Now, if you have further stretching, we are very sure that it's gonna lead to further decline and at times near blindness. So in a situation, to answer straight, I would really go and attack, start with the steroids right from the CT scan place to decrease the edema, and then attack the tumor. If you are happy enough, go again through the transnasal route. If you are not, then go ahead with a craniotomy. Do whatever as early as possible to help the vision, because the longer he does not recover the vision, the lesser would be the chances in the future for him to get back his vision.
Ashish, I will tell you what I did. I saw that there was a residual tumor. When we saw on the during surgery with endoscope, we felt that fairly good amount of the tumor is out. We went immediately within 2 hours And what we have found, there was a residual tumor which was significant size. We have removed it completely. And while removing, the superior portion was adherent to the arachnoid around the this diaphragm. So to scrap the tumor, that diaphragm got open. And after opening the diaphragm, I could see both the optic nerves, I could see the chiasma, and I felt a fairly good amount of decompression has been achieved. But believe me, the chiasma didn't fall. It didn't fall. Anyway, we have done as your good ENT colleague, I have got a good ENT colleague. He did packing and he did head flap, and we have put a lumbar drain, and some vision started coming. Now, we have done an MRI post-operatively. The tumor showed complete recovery, complete excision, but the radiologist felt some hyperintense signals in the optic nerves. And we have not touched the optic nerves. We know it very well. And second, he says this is an entity called ischemic optic neuropathy, posterior ischemic optic neuropathy, which can develop because of the atherosclerotic vessels. Now, to be honest, I was not aware of this entity, but this is what has happened. We have given enough of steroids, everything. But this problem I have faced for the first time. There was no hematoma. And now also patient is with me, slight improvement in the vision, but not a great vision. To my bad luck, after 10 days, patient developed a Csf leak. Now, what do? Immediately, I said, patient was little reluctant to go in again. So we put a drain in. Now, to my bad luck, patient develops tension pneumocephalus. And pneumocephalus is extensive. Patient became drowsy. So the drain was closed. First thing we have given, I give a lot of oxygenation to the patient to get an air absorbed. Luckily, the Csf leak has stopped. We have removed the drain. Everything is, the air is resolved, but the vision still remains affected. This is one of the worst complications I have seen in this kind of a tumor. And it was a giant pituitary, I don't deny. And believe me, what you are showing, the perimetry, exactly similar perimetry was of this patient. Now, unfortunately, this patient has also got a cataract associated, which is almost mature now. So we don't know whether only cataract, because afferent pupillary pathway, excellent. The light is going inside, pupils are reacting, he sees some light, but vision has not come back. This is what I'm facing a problem within one patient recently. So something worth, and I know very well we were not at all aggressive in removing, we were very slow in removing the tumor, and foreign techniques were used. All possible things, whatever possible was there, we have used. But this is one. And the radiologist told me it is a posterior ischemic optic neuropathy.
Yeah.
What is your experience here?
No, sir. I agree that any edema ultimately causes direct damage or ischemic neuropathy, as I had told you before. And this is a very unfortunate sort of a situation that we deal with, especially with giant tumors. And when we are presenting these giant tumors, especially to the younger colleagues, they should be well aware that what they are dealing with, and appropriate training. You should be aware of which stage of the learning curve you are. Need to read the radiology fairly well. I mean, an experienced surgeon like you facing these problems is in itself an indication that the younger generation should be aware that these complications can happen and should be avoided. Under all circumstances, you should try your level best. See, I lost one patient. That was a bad decision on my part. I was not ready for that case, perhaps. I did not think about the hydrocephalus pre-op. Led to a lot of hypothalamic complications. And so perhaps in giant tumors, a real good planning is required, and it's not just all giant pituitaries are not same. Each tumor is different, presenting entirely differently, should be planned differently, it should be dealt differently. So, and all giant and extensive tumors should not be attempted. So this lecture should under no circumstance send the message that all giant or large tumors can be attempted fairly easily through the endoscopic approach. Absolutely not, depending on your learning curve, your stage. Feel free to convert or to use cranial and endoscopic. There are transnasal as well as cranial. Do whatever best you can do to protect the interest of your patient. Now, I have one question here. How frequently have you encountered conchal sella and kissing carotids? Well, coming to the kissing carotids first, let me explain. Kissing carotids is an entity which is rare, uncommon. It is when the carotids come very near to the clivus inferiorly, and while you're drilling, there have been instances reported of injury to the clival carotids. And that is what, again, I come and say that use Doppler. Doppler is an extremely useful tool. It's a very cheap but extremely useful tool. And obviously to study your own, the patient's radiology. But the third most important thing is the eye sees what the mind knows. We all know this dictum. So if you're aware of kissing carotids, you're aware of injuring the clival carotids, then obviously in every scan that you review, you would look for the carotids in that location, and it should be done. So that is to answer kissing carotids. As of, if you ask me, I'm yet to encounter a kissing carotid. I have never found in my practice. The second part is encountered conchal sella. It is in Indian population, it is not a very common entity. You do have some aeration. In the younger populations, you would definitely have this type of condition, but of the sella. But generally, in large or giant tumors, this is not an issue.
I'd like to welcome Takashi Khan from Japan. Welcome, and to see if he has any comments. Welcome, Takashi.
Thank you. I'm Dr. Takashi Kon from Tokyo, Japan. Thank you for very informative lectures on endoscopic pituitary tumor. So sometimes we encounter some hardship the treating pituitary tumor. So it's very informative lecture. I appreciate that so much. It's 9 p.m. at night in Tokyo, Japan, but I'm keep attending this kind of seminar and keep learning. Thank you so much.
You're welcome, Takashi. I also like to welcome Omar from Syria. Hi, good day, Omar.
Thanks, Dr. John, and thanks for this very nice webinar. Very nice.
Thank you, Omar.
From the beginning, and I come late. It's very nice.
Yeah, Omar from Syria, Ashish.
From Syria. Okay. Thank you very much for all.
And do we have any more questions? Otherwise, Dr. Sumit is here. Yes. And we have a brief lecture of him. As you are all aware, Sumit, are you here, Sumit?
Yes. Hi, Ashish. Hi. How are you?
Hi, Sumit.
Hi, John. Hi. Nice to see you.
Nice to see you again.
Yeah, same here.
Okay.
I'm sorry I joined a bit late. I was stuck up in traffic. Delhi traffic is all everyone knows.
Okay.
Don't say all this, Sumit. I told them that you were busy in surgery.
No, thank you.
Okay.
Anyway, so let me introduce Sumit. Sumit and myself, we were together at All India Institute. We were trained together, and he took off a lot of load off me during my residency. Sumit is now practicing at Paras Hospital along with our professor, Professor V.S. Mehta. He has keen interest in minimally invasive brain and spine. He has been on this channel and forum before. And today he would be speaking on kyphoplasty and his experience. So all to you, Sumit, please.
Well, thank you, Dr. Ashish, for that introduction. We have been partners in crime together, and what wonderful years we had. And it's been always a pleasure to be in this forum. And always, whatever you say, I have to religiously abide by your orders, and that follows from not now. That follows about from 2 decades back. So, can you share my? Can you see my screen, everyone?
We can.
Okay, and can you hear me clear?
Yes.
Okay, great. So let's start. So my topic is vertebral body augmentation in osteoporotic fractures. And here, when I say VBA, vertebral body augmentation, I mean mostly kyphoplasty. And it's a beautiful technique. It's a minimally invasive technique, and we can do it by 2 ways. And hence 2 names are there for vertebral body augmentation. One is vertebroplasty and the another one is kyphoplasty. And for the residents here, vertebroplasty is simply injecting the cement through a needle, a spatial needle called as a Jamshidi needle into the fractured vertebral body, number 1. And number 2, kyphoplasty. In kyphoplasty, what we do is we take inside a balloon, inflate that balloon, so that it artificially creates a cavity into the fractured vertebral body. And in this cavity, later on, once we have inflated, made this cavity with the balloon, we take out the balloon and then we inject the cement into that. So this is the basic difference between the 2 techniques. And kyphoplasty is a advancement over vertebroplasty because in vertebroplasty, since there is no cavity, only the fractured vertebral body is there, there are high pressures of the cement injection. Whereas in kyphoplasty, because there is an artificial cavity which is created, what happens is that when you inject the cement accommodates itself into that cavity. And hence, very low pressures are there when you are injecting the cement. And hence, therefore, less chances of cement extravasation and subsequent complications are there with this technique. So with this brief introduction, let's sail forward through this topic. And just a minute, I'm having problems with this share. My slides, yes, okay. So what are those fractures which in which you are likely to improve with the standard medical management, and you will like to intervene with these vertebral augmentation techniques? First of all, fractures at the etherical lumbar junction. Now, why these fractures are very resistant to standard medical management therapy is because these are located at the junctional zone, meaning thereby the thoracic kyphosis meets the lumbar lordosis. Lots of axial loads are there in a mobile patient, and hence there is a propensity for these fractures to progress with time if you leave them like such. So there is a less likelihood of these fractures because of that axial load to get better on a standard medical treatment, and hence it is for you to intervene in these type of fractures with such type of treatments. Secondly is the burst fracture. Now the burst fracture, I would like to add in these burst fractures that the burst fracture is classically defined as that fracture in which there is a fracture of the middle column by definition. So if I say a burst fracture is less likely to improve with medical management, it is not like that it requires a vertebroplasty. However, vertebroplasty is a relative contraindication to the cement injection, because in this burst fracture, the posterior cortex of the vertebral body is slightly fractured. So if you inject the cement into that, there are some chances, especially in vertebroplasty, that your cement might leak into the canal with disastrous complications. So, to be very careful with these type of fractures while injecting the cement. Third type of fractures are wedge compression fractures, which have a 30 degree of sagittal angulation, which these fractures are less likely to improve with therapy, hence the need to intervene with vertebroplasty or kyphoplasty. Fourthly, if you find a vacuum shadow in a fractured body on a röntgenogram, which this suggests ischemic necrosis of the bone. Hence, such type of fractures are less likely to improve with medical therapy. And of course, if you find fractures which are progressively collapsing on the radiographic follow-up, the sagittal angulation is progressively increasing, or clinically your patient is coming to your clinic on a regular basis complaining of increase in the backache. So this is an indication for treating such type of patient with the vertebroplasty or kyphoplasty. So these are the developments, especially in the treatment of osteoporotic collapse fractures, and such type of fractures, as the name suggests, they are found in elderly females, particularly because of hormonal reasons. The bone density becomes less, and the bones are more prone to spontaneous collapse and fractures. The goal of the vertebroplasty is to confer the strength and stability of the vertebral body, and whereas the kyphoplasty also have one additional advantage of restoring the vertebral body height in a better way as compared to vertebroplasty, for reasons I mentioned before. And this, in addition to increasing the strength, also improves the sagittal alignment. Now, the indications of vertebroplasty and or kyphoplasty are the patients who obviously have failed conservative treatment plan, the patients who have pain strictly localizable to the fracture level. So in the clinic, if you are selecting your patients for such type of technique, your clinical examination should be is of paramount importance. You have to examine the patient, and if you find point tenderness over the fractured vertebral body, this is the patient who will definitely improve magically immediately after your cement injection. Thirdly, if the duration of the pain from fracture is greater than 6 weeks, but less than 1, or at the most in case of kyphoplasty for 2 years. So the selection of the patients is very, very important in order to have a good outcome after this technique. These are the contraindications where you have got a severe wedge deformity, and the height of the vertebral body is more than is only 10% of the normal vertebral height. So the vertebra becomes almost like a vertebra plana, as we call it as. In cases of comminuted burst, as I already mentioned, this is a contraindication, and you should not refrain to try injecting the cement into such type of fractures, because there is a high chance that the cement might leak into the spinal canal. The canal compromise more than 20%, you have to, in addition, either do a decompression, laminectomy, either minimally invasive or open, in addition to doing a cement injection. Epidural tumor extension, if you put in a cement, then the cement might leak into the spinal canal, hence it is not indicated. Or if the patient is unable to lie prone, because this is much better done in a much better way if the patient lies in a prone position. And obviously, if a patient is not fit for any invasive procedure like uncorrected coagulopathy, sepsis, or cardiac disease, you can do that. In cardiac disease, well, you can do, because most of these procedures are done under local anesthesia, but then clearance by a cardiologist is mandatory in such type of patients. Or in case if you are clinically not sure as to the cause of the pain is the fractured vertebral body. So the patient selection is the most important in the successful outcome of these techniques. Now, how does the pain gets relieved with the VBA procedure? There have been proposed several mechanisms for pain relief in such patients. First is the improved load bearing. Now, the vertebral body gets strong, hence it shares the load. Again, it starts sharing the load, and hence there is a lesser and lesser propensity for that vertebral body to get collapse under axial loading. The fracture gets reduced. The height of the vertebral body is restored with kyphoplasty, and some people say that there is a direct tissue toxicity for the damaged nerve endings in the vertebral body. So when you inject the cement, these nerves get killed and they get destroyed, and hence the pain originating from these nerve endings gets finished. And lastly is the thermal damage of the cement. Now, when the cement sets in, it starts a exothermic reaction. It becomes hot. The temperature becomes more, and this high temperature also can lead to damage to the nerve endings, which cause pain in such type of fractures. Now, as I already said, pre-op evaluation is has to be quite meticulous in selecting these patients for these techniques. A complete neurologic examination documenting any motor or sensory anomalies, in addition to identifying any existing radiculopathy. So first of all, X-ray is done, both epilateral view, and I personally prefer to do also a dynamic flexion and extension lateral X-ray to get an idea about the instability of the spine, if there is any, and if there is, then I would prefer to fix that spine percutaneously, maybe with pedicle screws, in addition to doing kyphoplasty. NCCT of the region is mandatory to identify any posterior cortical disruption of the vertebral body. Bone scan, yeah, plus minus, you can do that, and it can help you in identifying any malignancy if it is there. But then acute osteoporotic collapse fractures also will be brightly enhancing in the bone scan. Yes, but it can definitely localize the symptomatic level. And MRI is not generally recommended, but however, if the patient comes with the acute history of a fracture, MRI can be very, very helpful. And of course, if you want to differentiate it from a malignant fracture, the MRI of the spine is quite helpful. Now, this is one such X-ray of a osteoporotic collapse fracture. You see there is a sinking of the superior end plate of this vertebral body, and this type of fracture is ideal for either of these two type of techniques. And in an AP view, you can see this X-ray, there is the total height of the vertebral body is decreased. There is a flattening of the superior and the inferior end plates have come closer together, and the CT scan also shows and confirms the same findings. Here is one MRI which shows that this fracture is an acute one. Now, this is a specialized MRI sequence called as a STIR sequence and short tau inversion recovery sequence, and this helps you in identifying the age of the fracture. And if you get this thin line in the vertebral body, thin hypointense line in the vertebral body, this suggests that this fracture is less than 6 weeks old. And yes, you can do kyphoplasty or wait according to what the clinical situation demands. Venography, I personally don't do this venography very often, but it's recommended in textbooks to do a vertebral body venography, and this suggests the status of the lumbar vertebral venous system. And what you find is if the contrast runoff from the vertebra is rapid, then the shunting into the IVC is very likely, with attendant complications of cement embolization into the pulmonary vasculature. So yes, it is recommended theoretically, but I personally have never done it in my clinical practice. And yes, but it definitely helps if you find one. Well, transpedicular cannulation is possible in vertebroplasty from T5 to L5 and from T10 to L5 in kyphoplasty. And vertebral fractures that are compressed to a level below the pedicles, they may not be treatable with this technique, because you have to cannulate the pedicles with your Jamshidi needle. This is a mandatory procedure. This is the equipment which is used in this, and in the first picture you can see the Jamshidi needle. This is a specialized needle which you insert it into the pedicles, and so you can see the tap here, and the cement which is marketed by various companies, and they typically come in two forms. First is the powder form, and the other ampule of a liquid form. So what we do is we commonly mix 5 cc of the liquid monomer. This liquid is a monomer, and the powder form is a polymer. So we mix the two and wait for, there is a settling time after you mix these two products. So different companies have got different settling times, and typically it's about some 5 to 10 minutes, varying from different companies. And what is the ideal settling consistency? At that ideal settling consistency, the cement is said to be ready to be injected at that moment of time. So this consistency has to be just like a doughy consistency. It should be a caulking material consistency. It should be stiff, without any sheen. And when you inject it when you drop it, press it from the syringe, it should not drop like this. It should be a straight line for some time and have with a tendency to rise up when you inject it from the syringe. So that indicates that this is the correct time that you inject the cement into the vertebral body. It is either not too soft or not too hard, obviously, because then it would be impossible for you to inject. So this is, with this basic introduction, let us proceed forwards as to how to do it. So these are my handmade drawings, and then you see here, these are the pedicles. The outside that you see in the first picture, they are the AP view of the spine with 2 owl's eye, which suggests the pedicle. So the entry point into the pedicle is shown in the second figure. In the first part of the illustration, you see the entry point in the AP view. So always adjust the C-arm in the AP view first and see your entry point. What you do is you divide the pedicle into 3 parts, the superior, middle, and the inferior part on an AP view, and your entry point is at 10 o'clock or 2 o'clock position, or 9 o'clock or 3 o'clock position. I hope I'm clear regarding that. So the entry point should be and the outer edge of the pedicle at the junction of the upper 1/3 and the lower 2/3. So as soon as you mark the entry point with the Jamshidi needle, then you are allowed to go into the pedicle. So keeping the Jamshidi needle on this entry point, then you advance your Jamshidi, hammer it, or slowly push it with your hand, depending on the consistency of the bone. And most of the bones of these patients are very, very soft, and you can manage to push the Jamshidi with your hand rather than hammering it with a mallet. Sorry. Now, when you advance the Jamshidi, one critical technical point is that an average pedicle is around some 1.5 to 1.8 centimeters long. So it has to advance to this length, and you've got markings on the Jamshidi needle. Every 1 centimeter, you get a marking. So when you advance your Jamshidi through the pedicle, it should advance to this length, 1.5 to 1.8 centimeters, and then only it should reach the medial margin of the pedicle. If suppose it reaches the medial margin of the pedicle before this length, this means that there is a problem with your direction, the coronal direction of your needle, and it is probably entering into the spinal canal. So this is one important technical point. Now, when you advance the Jamshidi to about this much length, then you see the projection on a lateral fluoroscope, lateral view. And your needle, you should aim your needle to sit on the anterior-inferior end of the vertebral body, about at the junction of anterior 1/3 and the posterior 2/3. So this is the ideal length if you're doing a kyphoplasty. Now, why I'm saying this is because, as you can see in the illustration, the balloon of the kyphoplasty balloon, it sits in between these 2 points, which I have marked over here. And this balloon should rest just below the part of the fracture of the vertebral body is. Because if this balloon is elsewhere, it will not raise the fracture. So you have to see and study the preoperative CT scans and preoperative X-rays very carefully, and then decide as to where to rest your needle while inserting the Jamshidi needle. So this is how you insert the Jamshidi, which is the first step in a kyphoplasty or a vertebroplasty. And accurate placement of the needle should be in the anterior third of the vertebral body, as I already mentioned. This is because the anterior half of the vertebral body sustains 80% of the axial load. And secondly, the main venous drainage of the vertebral body begins at the midpoint of the anterior posterior dimension of the vertebral body. So if you are placing your needle in the anterior half of the vertebral body, there are less chances that your cement will run off into the venous system, with less chances of subsequent the cement embolism. So that is why you place your needle in the anterior half of the vertebral body. Now, these are some small technical points which one should remember while doing a kyphoplasty. If the patient has a superior fracture, then the tool should be placed inferior to the midline of the vertebral body, number one. If the fracture is through the inferior plate, then the needle should be placed just superior to the midline. If the height of the vertebral body is 1.5 centimeters or less, the needle should be aimed at the midpoint of the anterior cortex on the lateral view. Because the height is less, you can't manage to put the needle somewhere else other than the midpoint of the anterior cortex. And the kyphoplasty cannot be done if the height of the vertebral body is less than 9 millimeters. That is, if it has become a vertebra plana. So that's about small technical points. And when you, the sequence, let me tell you right now, straight away, after you insert the Jamshidi needle, what you do is you insert the guide wire, and then over the guide wire, take out the Jamshidi, and then insert a stellate through which you can insert your balloon device, as you can see in the first picture and the second picture. Now, once you have inserted your balloon device through that stellate, you can see in the lateral fluoroscopy that your balloon device is properly placed into the vertebral body. And those 2 points, those 2 dots that you see, they have to be accurately placed into exactly that area where you want to raise the fracture. Because it is here only that you may be able to make the cavity and fill the cement there subsequently. Now, once you have inflated the balloon, there is a procedure for inflating the balloon also. You do not inflate the balloon fully in the first go. You have to make subsequent slow increments in the pressure. And there is a pressure device also, which tells you how much is the pressure with each filling of the balloon. And how to fill the balloon is, you hold this gun into the hand, and then this handle rotates. Now, one subsequent half rotation, it corresponds to about some 10 to 20 psi increase in the pressure into the cavity, depending on the make of the kyphoplasty device. So you keep on turning the handle of the gun, and the balloon keeps on inflating inside the vertebral body. So this is how you inflate the balloon and create a cavity in a kyphoplasty. And once when you have created a desired cavity, you take out that balloon, and then you are ready to inject the cement. Now, the timing should be very important. You have to instruct your assistant to start preparing the cement about 5 to 10 minutes before you do a inflation procedure. Because if the cement is very soft, then it is not ready to be injected. It can come out, it can cause disastrous complications. And if your cement is hard, then also, of course, you won't be able to inject it. Now, when the inflation should stop? Inflation should stop when the desired reduction is achieved on a lateral fluoroscopy. Secondly, when the proximity of the balloon. Hello. Hello.
Yes, doctor, we can hear you and we are still seeing your screen.
Just a minute. There is some technical glitch. I don't know where my slides have gone. Just a minute. This is strange. I might have to stop the share. I don't know why it has happened. Just a minute. I'm extremely sorry for.
No, I think I may have caused that. I'm sorry. I'm sorry. I clicked the wrong button.
They suddenly went off the screen.
Yeah, I'm sorry about that. It's my fault.
So just a minute. I'm trying to retrieve that slide of mine. Yeah. Okay. Okay. Can you see that?
Not yet. Not
Okay.
yet.
Okay, sorry for that. So, secondly, I was telling when the inflation.
I'm sorry, we don't see it yet. We don't see the screen yet.
Just a minute. I have to share it again, I think.
Yeah, please.
Actually, just a minute. Actually, you might have to promote me to a panelist because here.
Okay. We'll get it. Okay, you are a panelist now. So just start again. You are a panelist now. There you go. Okay. There you go. Oh, yeah. Is that the correct slide?
John, can you see my slide?
Yes, we can.
Okay.
Inflation should stop.
Yes, correct. So I think I was saying that the inflation should stop when the desired reduction is achieved, or when the balloon reaches the cortical walls on a fluoroscopic view, or when the pressure readings remain at the maximum of 220 psi, because it is the limit which has reached of the vertebral body to expand. So there is no point in going beyond these pressures. Lastly, when the maximum rated volumes read from the inflation syringe, volumes of the cement have reached. So these volumes are 4 cc for a 15 millimeter length, or 6 cc for the 20 millimeters length. So these are the endpoints of the inflation, and always inflate in small volume increments, alternating in both the sides. So what I do is, I do it on both the sides. I do a double balloon kyphoplasty on the same side, in the same sitting, alternating in between the two. I increase the pressure on one side to a bit, give it a rest, and shift onto the other side, and then increase the pressure and then turn over to the previous side. So this is how it should be done. So these are the sequential photographs. I already explained that. And generally it is recommended that pain is elevated with 3 ml of methyl as effectively as with larger volumes. And of course, it depends on the volume of the vertebral body. What we have seen is the volume of the body is in an Indian population is lesser as compared to what is in a European or US or UK guy. So I mean, in Indian patients, 3 ml is as effective as large volume. There's most of the times there's no need to inject more than that. But if the stability is also a desired goal, then volumes, you can inject slightly more volumes as compared to what. So these are some sequential photographs taken from one of the patients I operated for kyphoplasty. You can see a wedge compression fracture there. Patient is lying prone. Now this patient was done under general anesthesia. And you can see the pedicle entry points with a Jamshidi needle. And this is the two Jamshidis in place. And this is the same on the lateral view. And then the Jamshidi is being taken out over a guide wire. No, the two Jamshidis are in place and the stellates are in place, and then you insert your balloon catheter and your stellate first and then your balloon catheter here. So these are the two balloons which are mounted on both the sides, and your patient is ready for creating a cavity. And there you see the two dots which I was talking about, and these dots mark the limit of the cement, of the balloon, So your balloon will inflate, and subsequently your fracture will be elevated only within the confines of this two balloons. So this is very, very important to place this balloon in a correct position if you want to have a geometric resolution of the fracture in a better way. And this is what the inflated balloon looks like, and the final cement placement into that created artificial cavity. A short video, maybe 2 minutes, if the time permits, otherwise it's fine. John, what do you say? Huh?
Yeah, that's fine.
Okay. So this is what I used to do before when I had an OARM with me under OARM image guidance navigation, but it is not mandatory at all. You can do it very well under fluoroscopy. And you see inserting the Jamshidi needle, and you see the direction of my Jamshidi needle. It's not the same as you insert your pedicle screws. It's going downwards, and the aim is, you see my cursor over there. The aim is the anterior inferior end of the collapsed vertebral body. So this is
confirm करते जाओ. हाँ है ना इनके पास जमशीदी.
And then you insert your guide wire.
Sure.
Take out the Jamshidi very, very carefully, because this guide wire is the railroad over which you put your stellate, through which you have to put the balloon. So this guide wire should not get displaced while taking out the Jamshidi needle. So this is very important step. You take out the Jamshidi, and with the guide wire, then you insert your stellate over there.
Give me, where are the, yeah.
And then you see on the fluoroscopy, and then you take out the guide wire once you have put your stellate into the vertebral body.
I'm ready to take the balloon inside.
The balloon,
okay,
and putting it, loading it through the stellate. Now this is the device that you see in my hand there, and that is
you can see this side and plate as well.
Cement, and looking in the fluoroscopy as well.
It's heavy.
So when you inject the contrast in the balloon, you can see it on fluoroscopy, and then you can see
precautions we should take before inject. Yes, sir. Yes, sir.
Huh?
We are seeing you, sir.
Okay. So normally, if you are not using navigation, then there are two techniques: either freehand technique,
okay,
or
so that's the sequence of the that's how you do it. And well, the complications, if you do surgery, there will be complications, and no surgery, nobody can say that there are no complications in any procedure. Yes, this procedure, howsoever minimally invasive it is, it carries its complications, right? And the most common complication is cement leakage. And mind it, most of the complications that do happen with this approach is when you make a wrong patient selection. So if you are taking a patient for kyphoplasty in a patient who has a burst fracture with a fracture in the posterior wall of the vertebral body, thus you are inviting for problems. And what problem? The cement will leak into the spinal canal, and the patient will wake up with a functional deficit. Pulmonary embolism can happen if you inject your cement too fast, or your cement is too soft or too liquid to inject. Adjacent fractures, yes, this is a thing of concern. What happens? There is a shift in the mechanical dynamics of the spine once you inject the cement. That particular block of that particular unit of the body of the spine, it becomes very, very strong. and the others and the load distribution becomes unequal, and these adjacent vertebral bodies are prone to fractures at a later date. So infection, yes, with any procedure, infections can happen. So the take-home message is that osteoporotic collapse fractures, they cause significant causes of morbidity in elderly patients. Conservative management, yes, you can try for 4 to 6 weeks, but after that, if the patient is having these persistent backaches with progressive increase in the sagittal angulation, with progressive compression of the vertebral body, you have to try some sort of VBA procedure. And generally, it is done 1 to 2 weeks after the fracture in cases of kyphoplasty to up to at the most 1 year in vertebroplasty. As I said many times, careful patient selection is mandatory. And this procedure is one procedure where you can 100% guarantee dramatic pain relief to your patient immediately after the procedure. Your patient will come happy, smiling when you see him out of the OR. And it is very, very safe with minimal or no complications. Thank you so much.
Okay, thank you very much. Ashish?
Thank you, Dr. Ashish.
Ashish, are you there? Okay, if not, any comments or questions from the audience? Ashish may have stepped away.
Hi, John.
Go ahead, Arshad.
Hi, Sumit.
Hello, sir.
Hi, Dr. Ashish Parekh from Mumbai. Nice demonstration. I liked it.
Thank you, sir.
Yeah, nice. I just had some queries to ask you. When you prepare a cement to inject through the needle, the consistency of the cement, when you prepare between the fluid and the powder, how do you judge, okay, this will not stick inside and it will go? Means doughy filling means it is semi-solid. It's not liquid. The problem, if it comes, if you inject and the needle gets blocked very fast.
Yes.
Yeah, so that is the problem. Even if you then try to inject with the skillet and then the cement doesn't go in. So what is the judgment? How do you judge?
So that's a very good question, Dr. Arshad. I mean, this is the crux of the entire kyphoplasty or a vertebroplasty procedure, because the consistency of the cement should be just appropriate. It should not be very soft. It should not be very hard for the reasons I mentioned before. So what happens is you have to instruct your guy that you have to personally check. What you do is they make about 5 to 6 aliquots of the cement in 5 to 6 syringes, right? And whole of the cement they make at one point of time, and then in all these 5 to 6 syringes they keep on checking. They keep on checking by injecting the cement through the syringe outside. So when the cement is ready and you take the syringe in your hand, you personally check by injecting the cement in the air. And when the cement comes out through the needle, that is to me the most important point of time that I am ready to inject the cement. So when the cement comes out of the needle, it should not drip like this. It should not drip. This means that if it is dripping, this means that this is very, very soft and it is not ready to be injected. It should, when you inject, it should come out in a line for a while, and maybe it should rise up. Maybe it should rise up. When it rises up, for me, it is the correct time ready for injection. So when this happens, this means that you have about 1 minute window or 1.5 minute window that you can inject the entire cement into that body. And this consistency is a caulking material consistency, which is a great consistency to work with the cement.
Now, when you put needle on both the pedicles, so we should inject both at a time?
Yes, my stellate is on both the sides. On both the sides, I'm ready for injecting on both the sides at the same time. as I showed in my video. And then when the cement is ready, I have about 1.5 minute window to inject that cement into the bone, or maybe more, 2-minute video. So because various cements have various settling times. And nowadays, what I use is the Depoy cement. It is a very good cement, which has got a very, very easy, comfortable time window to settle in. And basically, some cements are those cements which settle in very, very late. So you have to judge this accordingly, depending on the supplier, the cement supplier, I mean, and accordingly act. The end point of that cement preparation is when the cement does not drip in, number one, when the cement flows in a straight line, or maybe very good if it rises up a bit when you push it from a syringe.
Correct. And from each needle, how much cement you use? I use 2 ml syringes.
Yes, 2 ml syringes. I mean, these are the general equipment which comes in, and generally I inject in a total in one vertebral body in an Indian patient. I have injected at the most 6 ml, 3 ml on both the sides. So because our Indian population, they've got small vertebral bodies, unless the patient is very, very obese or things like that. But you don't require more than 3 ml on each side in most of the circumstances at one level.
How many levels you do at a time?
Well, it is recommended that generally don't try more than 20 ml at a time. And so I can work with, I have worked with at the most 4 levels at a time, not injecting more than that.
Right. Worry is the leakage of the cement. If it leaks in a canal, then there is nothing you can do.
Well, I mean, this is a very, very helpless situation that you are in, and our entire neurosurgical spine procedures are under neuromonitoring, and it is the worst sound of life when your neurophysiologist shouts on you that the potentials have dropped by more than 50%. So, I mean, we can't do really anything in that situation. Theoretical situation, yes, if you can ask me, it has never happened to me, touch wood. But if it happens, then theoretical situation is to open and make an incision, open the spinal canal, and irrigate with lots of saline. That's the only situation that comes to my mind.
Can I jump in?
Yeah, Ashish, go ahead. Go ahead.
Basically, I'm more of a vertebroplasty man, and whenever I see a streak of cement going in, I immediately stop pushing the cement through the syringe. What I do is I just take a little bit, say 0.3, 0.4 ml of cement, push it, which is within the needle, and then just push gradually with the trocar. Sort of, in my cases, that is a much more controlled fashion technique. The second is, in vertebroplasties, unlike kyphoplasty, we use the other needle on the opposite times. At times is a pressure valve release. So, here from one side we are injecting, and in case if the pressure builds up, sort of it helps come out from the other, or saline at times. So these are two technical tips that we take into our practice. So whenever we have a doubt of the streak, we immediately do not push it through the syringe. I somehow feel it is a little more uncontrolled.
Yeah, I experience the same way I feel. I'm also doing only vertebroplasty, kyphoplasty, rarely, because of the cost factor, nothing else. I try to inject, I feel little more liquidy rather than more doughy, the cement. And I take in a different fragments of the powder and the fluid and make a cement and judge whether the cement is ready to set in. And after injecting, once you see on fluoroscopy, it is entering, just stop it and then use your trocar slowly to go in. Yeah, same way. Yeah. Good point.
So, friends, do we have more questions to Sumit? Or any questions for the first lecture? I'll be more than happy. So any questions to any of these speakers?
Okay, I think you covered pretty extensively. I'd like to thank both you guys for a complete presentation, very interactive. It was good today. What do you think, Ashish?
Oh, yes, absolutely. It was much more engaging. And I think Sumit always comes up with lucid presentations which attract more
Always
questions.
behind you, sir.
Yeah, thanks for coming by, Sumit. And you're
Thank you,
welcome to come to any of them.
Always for you.
Thank you. I thank you for coming by, Takashi, Omar, Arshad, Stephanie. Thanks for moderating. And we'll see you in 2 weeks, right, Ashish?
Yeah, the next time we have again the next series in which Professor Teo would be speaking on mesial temporal lobe tumors. So that would be a keyhole approach. So he would be talking on that, and we haven't finalized our talk on spine, which I'll inform you once it's confirmed.
Okay, and we'll be promoting that. So, okay, thanks everybody, and we'll see you next time.
Thank you.
Thank you. Bye.
Thank
Good day.
you. Goodbye.